got a couple of cases which we would like to discuss with you. And to do that, we've got some discussants up on the stage here that will interact with you in relation to these two cases. So I'd like to invite again, please, Dr. Titus Lau, Dr. Crystal Lim, and another discussant who I haven't introduced yet, so I will do that now, Associate Professor Sharon Kaur, who's visiting from the University of Malaya and has a great deal of experience and knowledge in clinical and research ethics. So could I please ask the three of you to join me up here? So since 2010, Madam Ng, who's 44 years old and a housewife, has had type 2 diabetes and hypertension. She consequently developed diabetic kidney disease because of poor adherence to glycemic and blood pressure control. And Madam Ng did not attend outpatient medicine clinic and hence did not receive consistent treatment for DM and HPT. However, she's presented herself to the ED where she has symptomatic medical conditions. Recurrent ED visits were made for gastric discomfort, diarrhea, fever, foot infection, dyspnea, leg swelling, giddiness, and various other conditions. But each time, she asked to leave ED or the ward once she feels better after the initial treatment. She frequently declines a whole load of monitoring and tests and declined to follow instructions that are given by the staff. So her behavior has led to multiple episodes of abscondment and discharge against medical advice from the ED or ward, and she has told medical staff that she could leave because she feels better and would report back to the hospital if she's feeling unwell again. Now, Madam Ng's kidney disease has now deteriorated, and she presented to ED with symptoms of uremia and significant volume excess. The clinical course was consistent with end-stage kidney failure, and she needed life-sustaining long-term maintenance dialysis. Given the background, the renal team called in the psychiatric team, and together they assessed that she had capacity to decide. So Madam Ng agreed to initiate dialysis via a catheter. She improved and was symptom-free after a few dialysis sessions. Before outpatient dialysis placement was finalized, Madam Ng absconded from the ward when she refused discharge by the medical team. The team later contacted the husband, and he reported the patient was home but could not be persuaded to return to hospital. 10 days later, she presented again to ED with symptoms of uremia and volume excess and wanted dialysis, and she improved after one session of dialysis. At the next session, she wanted dialysis stopped after 1 hour, saying it was taking too long, and when the nurses tried to calm her down and explain she needed to stay for 4 hours to complete dialysis, she threatened to disconnect the tubes. The nurses relented and terminated dialysis, and she then asked for, again, discharge against medical advice. The psychiatric team again reviewed her case and concluded she had capacity to decide to discharge herself. So this pattern of behavior has continued for 12 months, and even in hospital, she chooses when she wants to have dialysis, and that depends on her mood, and she becomes very agitated if she has to wait. Occasionally, she shouts at the nurses, and when she was denied discharge, she informed the doctors she no longer wanted dialysis, and she understood that the consequence would be death. If allowed to proceed with her choice of action, Madam Ng promised to comply with outpatient dialysis attendance, and when asked why she repeatedly doesn't come for outpatient dialysis treatment, she says she doesn't like waiting. So she has needed multiple ICU admissions, but the ICU stays have never been for long. So a little bit of background medical history. She was diagnosed with schizophrenia when she was in her 30s and been on follow-up at IMH. Her treatments included oral antipsychotics and depot injections, and she's not been admitted for psychiatric illness for the last 10 years. She's never been suicidal and has not exhibited psychotic symptoms in the past few years and generally adheres to her follow-up at IMH. Multiple psychiatrists say that her psychiatry is in remission and she does not have psychosis. Madam Ng, gosh, I'm trying to remember her name. It was Madam Ng, right? Married at 18. Her husband is a lorry driver, and he's the sole income earner. They have 3 children. They're mostly cared for by the patient's mother, but they do come home sometimes. They live in an HDB 3-room flat. She's independent and can care for herself. She's a smoker and drinks beer most nights, but the number of cigarettes and alcohol is limited by a daily allowance she receives from her husband, which is $20 a day. Right, so we've got some questions for you so we can have some fun and see what you're up to. So the first question, was initiating dialysis in her best interests when she was diagnosed with end-stage kidney failure, right? So then the next question is about 12 months later. So we're talking about that earlier stage. Was initiating dialysis in her best interest when she was diagnosed with end-stage kidney failure? So, interesting, isn't this? So 3/4 of you said, yes, it was in her best interest to initiate dialysis when she was first diagnosed with end-stage kidney failure. Oh, 10%, 11% said no, and 15% said unsure. So those were the three options we gave you, right? Yes, no, and unsure. Very interesting. Okay. I'm in two minds about whether to ask you the second question now or not. The second question is it still the right decision 12 months later? Shall we run that too? Yeah, I think let's do that. So we can do a quick comparison. On hindsight, 12 months later, was the decision to start dialysis still in her best interest? Do you still think it's in her best interest 12 months later, knowing what we know? Which is basically, you know, she hasn't been very adherent. She doesn't go to the outpatient dialysis center. She has to come in repeatedly for ICU treatment for uremia and volume excess. Is it still in her best interests? All right, so there is a change. How interesting. Okay, so we've gone from 75% basically saying it was in her best interests. We've now dropped to about half of you saying it's in her best interests, and a lot more saying no, when before it was like 12%, now it's 37%. The number of unsure still remains 15%, so that's quite interesting. So I wonder if it's the same group of people who still remain unsure and are hedging your bets, right? Hedging your bets, you're sticking with the 15%. Oh, now 16%. Okay, very interesting. So I'm going to now kick off the conversation. And, well, I mean, we could certainly start the conversation within the panel, but bearing in mind these two responses that we've just had from Paul Evie, and also the talks that you heard from this morning, would anybody like to start us off with a question? Don't be shy. We do have a roving mic, and we've got two mics up here. And if not, I know people who already have questions, right, JJ?
No, but I'll start you off with a comment about question 2.
Yeah, hi.
I'm Richard, I'm from NUH. Just because she doesn't consume dialysis resources in the way that we would like her to, does that make it not in her best interest to seek health care when she needs it?
Titus, can I?
No, I'm fully agreeable with you, Richard. I think that's what we are here for this morning. We are here to answer tough questions. I'm hoping to listen to you all, and maybe you could give us guidance as well before, we ask my esteemed panel to share their opinions. I think that is definitely one side of the story. If someone cannot comply with what seems reasonable to us, but yet, as you've read from the case history, does desire to be treated, but in a manner that she sees as appropriate for herself. I think I had a bit of a discussion with Giles just before coffee break about how in his patients as well, sometimes that they have capacity to make decision, but they don't have good insight into disease condition. And that's what we're facing here today. So perhaps we can hear from other members of the audience and share with us openly what you think, as how you voted and why.
Hi, JJ from Tan Tock Seng Hospital here. I'm just wondering whether one of the elephant in the room in today's discussion is actually the issue of resources, which is actually in our context finite. Perhaps Richard didn't touch on that because under NHS, everything's free, and of course whatever that's affordable on the menu. Just move Doctor around. Okay, yeah. Okay, so in our system, I mean, we're talking about a system where there are finite resources, there are competing needs, and one of the things we often struggle in a hospital, in other words, in a real scenario, which I think Titus and Crystal will realize, will concur, is that we often find competing interests. And these interests are actually best interests for different individuals. And often that is where we find that it's not a clash with autonomy, it's a clash with maybe distributive justice. Yeah, and I think that here, I think we have fairly clear examples of how when one's best interest erodes another person's best interest, there has to be some control in a society where we share communal spaces and all that. One example is smoking. You may think it's in your best interest to smoke, but if your smoke causes health issues in others, then you have to be contained. Now, in this case, while it doesn't look obvious, but to me, sometimes I think that here's a person who would not comply, who feels that it is his or is it her best interest to not take the medication, not comply to, so she's a typical example of what we call happier SG. Yeah, but not so healthy, but happier SG certainly. And but then when she has trouble, she comes back to the system to seek to get treatment. And often this kind of treatment is expensive because they come back very sick. Now here you are actually eroding into the healthcare resources that are supposed to be shared with others. So shouldn't there not be some level of containment in this? Because just as we are sharing the same airspace, here we're sharing the same amount of healthcare resources. And I think that, so the elephant in this room here is, everybody has their own best interest, but when that best interest causes a sort of, curtails other people's best interest, then how do we make that decision? Even in terms of caregivers, many of the decisions that we offer to our patients actually has an impact on the best interest of their caregivers and the people around them. So, and quarantine during COVID is an example where we have to forcefully isolate people because otherwise it will affect the best interests of surrounding patients and people. So I think that's my comment.
Thanks. Anybody want to follow up specifically on that? Sharon.
Yeah, just a specific comment. I mean, I think that's a really interesting point. But I'm just thinking at the levels at which different decisions are made. So when you talk about distributive justice and having limited resources, I would imagine that these are made at a policy level or at a national level. We can only offer, let's say, dialysis to patients who fulfill this particular medical criteria. So then, as long as they fulfill that medical criteria, you're offering them that service. If you then have a distinguishing and saying, well, it depends whether you're compliant or you're not compliant, I'm not quite sure whether it still remains an equitable notion of distributive justice, because now you're dividing it based on whether we think you're actually going to do what we want you to do. And I think it becomes even more problematic when you then add on this level of incapacity, where we're not even thinking about whether you're compliant or not compliant where you have capacity, but actually if you can't even make that decision for yourself, when we decide what is in your best interest, we are now going to take these limited resources. And I think, I have no answer, but I think it becomes even more problematic from a justice perspective.
Yeah, I agree. I think ideally it should be a sort of policy-driven sort of thing. And it's sometimes difficult for the doctor by the bedside to make certain decisions. But I think we also need to look at beneficence from a more comprehensive and longer-term sort of perspective. Because in this patient, your dialysis is going to help her problem now. And then she goes back into her own ways. And then the next crisis comes. And one's got to ask this question about, is this person living in an island where, she is not connected to any other external system, and that as long as I can benefit and rescue her each time, but what is the long-term sort of benefit for this patient? And therefore, I think that, here I'm not sure whether the principles of proportionality and social responsibility has to come in. Yeah, I think if this resource is driven from society itself, then I think some form of social responsibility would have to be exercised. And whether the doctor who's managing the patient needs to see beyond just the short term, we have encountered sometimes doctors who tell me that, I'm just a technician. You tell me if you want to dialyze this patient, I'll dialyze for you. You don't want to dialyze the patient, I will not dialyze, but please make the decision. But I think that, being the doctor responsible for the overall well-being of the patient, I think we may, my sense is that we just can't be looking at the problem that is ahead before us now, and we have got to look at what exactly is the ultimate goal for this patient, because giving the patient that treatment this time without a therapeutic contract after that would just be perpetuating the whole vicious cycle. So I know that places where, one example was years ago, I may have shared this in some forum, that there was this, in America, if you know healthcare, you just get emergency care. So there was this hemophiliac who often get into fights, and he will present himself to ED with all sorts of wounds and bleeding non-stop, and they would have to transfuse all the clotting factors and so forth. And this particular hospital, because it was run by a Catholic organization, they felt that they need to be very thorough and comprehensive. So they offer more than just emergency care. But after a while, so how I knew about this case was because the legal officer of this hospital came to an ethics conference and asked for advice, because she said actually financially they're getting into trouble. And I think the answer then by some of the experts was that the organization needs to see its obligation to the patient, to patients beyond just that one patient. If that one patient is going to bankrupt the whole hospital and finally render them unable to help other patients, then they got to take that into consideration. So what they did finally was I don't know how successful, they had a therapeutic contract with the patient that if he were to come in again with that kind of injuries, they may not transfuse clotting factors. Now, I don't know whether it will work with this lady, but at least I think that's an attempt to put down some guiding principles that there is a limit to how much we can fulfill a person's best interests and address the negative consequences of what the person perceived to be his best interest. I think capacity was never a question here. It was an issue of social responsibility and obligation to all patients, all the patients that they manage.
Yes, Aaron.
No real answers, but more questions. The first is a bit more fundamental. If you say the person has no insight, then before we even talk about capacity, right, is the consent even informed, right? From the person, the way the person behaves, it's as if the information didn't seep in and they're doing everything opposite of what should be done. So the fundamental question was the consent even informed? And how do you overcome that problem? Because a lot of times that is the fundamental problem, and there's a certain discrepancy between the expertise and how we translate it in such a simple way, but yet lose its nuances if we translate it in a simple way. The second question is really the mental capacity or the decision-making process in terms of whether it's a micro-decision or macro-decision. So I think what we are arguing to a certain extent is, does she have a capacity to dialyze? But the question is, does she have capacity to manage her whole condition? They are two very separate questions. And so from the clinician point of view, if I'm just seeing you piecemeal once at a time, understandably, I'll be answering the micro decisions. But in this day and age of healthcare, where we're talking about longevity, chronic illness, and you're talking about longitudinal care, where one decision will affect the next, will affect the next, will affect the next, do we need to then helicopter out and ask better questions of what is the decision here, rather than the question that the team asked me to answer? Just some comments on what was discussed here. Thank you very much.
Oh, thanks, Aaron.
Maybe I'll just respond to JJ's first, and then to you. Again, I think this fits perfectly into what we are trying to discuss today. I mean, on one hand, if I'm thinking about it, if I ask the audience today, would you consider her a vulnerable adult, right? So she's not a sociopath. She didn't choose this for herself. She didn't say, I'm like you and me, I'm perfectly okay, I'm a doctor, but I will not have regular dialysis. I'm a nephrologist. I know the consequences, yet I come and seek emergency treatment every 10 days, right? You know from the background who she is. So is she a vulnerable adult that you need to care for? And again, back to what I think JJ put correctly, accountability and responsibility. Where do we place that within the context of best interest judgment or decisions that's made together with her in this case, actually, not on her behalf, because she still is deemed to have capacity to have shared decision-making process. You're absolutely right. That shared decision-making process has got to do with different kind of decisions. Decisions could be, to her, is a very straightforward. You know, this is someone, and I was going to ask this to the psychiatrist and to the pediatrician here as well, because you see a lot of this happening in terms of adherence and compliance to care in teenagers, right? They are teenagers, they do know certain things, and you consider them maybe perhaps still not mature enough to understand the longer-term consequences or have the foresight and insight to be able to manage or have preventive healthcare behavior, right? What they know is, I live, like you say, happy, and they are happy, and that's a good thing, right? We shouldn't deny happiness to anyone. You know, so they live day to day or week to week, and there's certain things that's important to them. You know, we receive a ethics referral from someone who's 19 or 20 years old. In this country, the age of majority is 21, by the way. For some of you who come from different countries, maybe 18 or even 17 or 16. But over here is 21 years old. And this is a teenage girl who knows everything, but she says, I don't like the way I look if I'm too dry on dialysis, right? So, and there's a lot of conflict with her nephrologist attending treatment and all. But she does come for treatment. Her parents try their best to persuade her, but that's in her mind. You know, she didn't choose it, I would say. This is who she is. So if you look at the context of a vulnerable adult today, would she fit that? And how far would society go to support her decision and the way she wants to live life? On one hand, I think we heard very, very clearly, and that's absolutely true. I think all of us are in the system. All of us know there is finite resources. All of us know we are steward of those resources and we have to be accountable. That's absolutely right. No discussion, no dispute about that. Again, from a humane perspective, and even as fellow human beings, we look at someone in that position. We look at someone who didn't receive good education, who has fairly low IQ perhaps. Do you protect that person? Do you write that person off? Because, well, you can't adhere to what society expects of you because it's a finite resource and everybody, taxpayer, have to work so hard to pay for you. And we don't think you're deserving to be in this situation. Yep. So I think that's the difficulty. As you rightly pointed out, I think for many of us, we admit that. I don't think we have an absolute answer to that, but that's why we raise this, so that I think it raises awareness and discussion, and really I just want to hear from everybody, and I think different people may have different viewpoints of this. Maybe Sharon and Crystal, too.
Hi. Yes. Hi, I'm Winlin. I'm from National Cancer Institute, Malaysia. Just wondering, for Madam Ng, I'm thinking the concept of time-specific decision-making. So I think when the initial decisions of going for dialysis, it does seem like it was in the best interest. I'm also wondering whether there were conversations ongoing about what is important for her, what is her values, and whether the multiple episodes of her absconding and coming back again, whether those were explored in depth. And although I did answer no for hindsight, that is not a good decision, because over time we discover what is feasible and what is not. And it does look like it's not important for her. But I would say that if I go back in time, even with the hindsight knowledge, I would probably still go for the dialysis at that point in time. I'm wondering what the comments from the panel. Thank you.
Thank you for bringing that up, because there's something I want to talk about. Just because on hindsight that she didn't behave well, for lack of a better word, they say, alamak, she shouldn't have started. We shouldn't have started her. I don't think that's the way to look at it, because she needed that treatment. And mental capacity doesn't require us to have full comprehension. And that's why it requires us to have adequate comprehension, material, or substantial comprehension, not full comprehension. If she knows enough that, and the threshold is different when saying, no, I don't want that treatment, because the consequences will be more grave than compared to, yes, I want the treatment. And we put the threshold for mental capacity, for comprehension higher when people want treatment, then we deprive those who are of lower health literacy and SES. So in her case, I still think that it is in her interest to have started. She's young, she's a mother, doesn't matter about her vices in her life, right? Because we're not here to make a moral judgment. So I still think that it's in her interest, but what I think is the problem here is a behavioral one. And therefore the distributive justice. As a social worker, especially because of the time, I was a renal MSW for a good decade of my life. And those days we were very resource constrained. So I'm very sensitive about resource utilization, something that I ask myself to guard against, because I'm very concerned about how people therefore behave. But the thing is, okay, she just need to have enough adequate comprehension to say, yes, I want the treatment. But because she wants to have the treatment doesn't mean that behaviorally she can manage it. They are separate issues. And I don't think, therefore, we should rule that decision just because she's difficult to manage now. It is very difficult to manage a non-compliant patient, we know that. That's my take on it. Yeah.
Sorry, quick comment and then we'll come to your question. Oh, are you okay? Okay, sure,
Hi,
go on.
sorry, Jerry from Changi General Hospital. I think this is a very interesting scenario, something we see every day, and I hear what everybody's saying in terms of social justice, equality, and all that stuff. And this is actually very pertinent because we actually have a very huge population of patients that require dialysis and have no slots, okay? And it's interesting because you talk about social equality and she deserves to have this, and you talk about vulnerability, she being a vulnerable adult. But there are a lot of people that are vulnerable and get into trouble. But do they explain because of their past experiences, their clinical condition, their low IQ, but they're still within a structure where they did something wrong and end up in jail. So to some extent, if you want to engage in some type of services, there's a kind of informal contractual agreement. You get taught by someone, you attend the classes, you seek help, you want to follow advice, we'll give you an option. It's hard for me as a clinician to deal with a patient that want to choose how she wants the stuff being delivered. And if she was allowed to have this special privilege, the director of the renal service would be pulling her hair out because every other patient say, why can't I do it on Wednesday and Thursday rather than Friday? So at some stage, you have to talk about rationalization. And we sometimes have to make hard choices. Where does the liver go? Where does the kidney go? And why can't we, even in this situation, make the hard choice that, yes, we could ask her to have a contractual agreement. If you want to have that, we can kind of tailor it, but the moment she has 3 strikes, I think we just have to be tough about it. Because from a societal point of view, we have to do what's good for society. I do understand and agree she's vulnerable. It's not that we haven't given her chances, we've given her services. But where does it draw the line where this is too much?
I certainly agree with you. Now, in the days of TT Ture, this will not happen.
That's why he had to go toilet.
No, this will not happen because it's very clear about the aims of dialysis. And so I think it's just, if we have a contract with her, like, how many, these are the things we need to work on, and these are the consequences, the negative consequences if you fail to adhere to this, because respect for autonomy has got limits, right? Because she's using societal resources. And what I see lacking now, and the reason why I bring in TT Dure and I have lots of respect for him, because we would have lost many patients if not for what he has done for renal care in Singapore. It's because he was very clear and he had the guts, he had the balls, really. He really had it, okay? And MOH listened to him. Right, but now I find that people are afraid of getting complaints because it's inconvenient. It may not be fear as in fear itself, but administrative. Oh, time is up. But I do think that renal service, in public hospitals need to come together because they shop from one hospital to another. I think there needs to be more consensus and really moral will about how things should be done because it's not sustainable. Like that.
But as a panel, a lot of times clinician or other people look to us for advice or a direction. And sometimes there are no clear directions. I mean, I
think it must come from on top. Sorry, I don't mean to interrupt because of the time. I think it must come from a top. It must come from a few people coming and say, hey, let's look into this. Because ESRD is a significant disease prevalence in Singapore. And then plus the aging population. It is something, and we need to move away from, as far as possible, move away from bedside decision making, bedside rationing. You know, and where physicians have lower tolerance for complaints or certain things, and they tend to give in to patients more. We are seeing that on the ground. So I feel that it's a policy and a systems issue, and it takes moral courage.
Completely agree. There were so many cases, especially even over the weekend, where the clinicians were not comfortable making a decision because policy from top, and like you said, the fear of complaints. But sometimes it's not enough for us being honest, not enough for us being open. Unfortunately, a lot of people want things they can't have. I want $1 million. I don't have $1 million. And if the patient wants things that is not possible, somebody has to be strong enough and brave enough to say, this cannot be done.
And we need to see that happen, really. Yeah. I say renal care, my own phrase, yeah? I mean, renal work is difficult. Yeah. I say renal care is massive and messy, because of all these issues. It's lots of societal resources involved.
Do we have time?
Titus.
Do we have time? Can I say
Well,
something?
yeah, well, we've got another 5 minutes before we move on to case 2.
So, just shortly, because this is something that I've been thinking really quite a lot about, this whole idea about capacity, surrogate decision-making. And it strikes me that we either leave patients, and this is purely from an ethics point of view, if we're really thinking about what is the right thing to do, understanding that there are limitations in terms of resources, in terms of the jobs that people do and their ability to have time, either we leave them to the tyranny of autonomy, where the minute you have capacity, the decision is completely your own, regardless of whether, and I completely agree with the gentleman, the difference between saying, yes, I want dialysis, and yes, I understand the consequences of being on a dialysis regime and my illness. And if you have capacity, it's completely up to you. Versus if we immediately then cross you over this border of threshold and say, well, now you don't have capacity, you become something, as Geneva Richardson said, an object to be acted upon. And then we use terms such as authority, safeguarding, protection, incapacity, best interest, and that's very paternalistic. Then we make the decision for you, or we find somebody to make the decision for you. But increasingly, I think I've really been thinking about the CRPD, the Convention on the Rights of Persons with Disability, which now include mental incapacity as a form of disability. And the philosophy behind the CRPD is that actually disability is socially constructed. And it's not, so if you try and think about capacity as also being socially constructed, and the idea behind the CRPD is that we think about support. So how do we support decision-making rather than just declare capacity or incapacity? So I'm just thinking again about Madam Ng, right? Whether it would have been possible at the point at which she showed a pattern of repeated presentations at the ED, that she's then flagged up, there's something wrong with this lady, why isn't she coming for her admissions or her regular inpatient appointments? Can we have a support team come, assess her and talk to her? Is it because she just cannot, she's just disorganized, she can't wait so long? Can we give her a number to call, that every time she needs something, she calls that number and we try and make that arrangement for her? Can we build a relationship for her so that if and when maybe you have to make a best interest decision, you genuinely have a support officer or somebody who is a healthcare professional who's got that narrative of understanding and following her through all these things, so that you don't then have all these separate ED instances where different doctors are seeing her. You have different periods at which she's actually presenting to inpatient doctors. So you're never really supporting her whole process and thinking about that decision making. So I was just wondering, whether even this capacity, no capacity, best interest distinction from an ethics point of view is really doing the work that we need it to do, and whether just then lumping everything on healthcare professionals or making policy and then bringing in, well, what does society want? Are we then moving 10 steps beyond where we are? And we've really failed to see what does it mean to support and enhance autonomy? How do we help people make good decisions and understand and maybe walk through these decisions with them, especially for chronic patients? Sorry, it took too long. Thanks.
Mayo.
Hi, thanks. I'm Mayo. I'm a pediatric hematologist, oncologist, and I just want to see it in a different way. So, for example, an analogy, if we get somebody with leukemia who is of sound mind and he refuses treatment, we'll say, okay, right? But he comes in with bleeds. We will treat him with platelets and give him good supportive care, palliative care. So I would argue that Madam Ng is kind of like that. Her dialysis is not going to cure her, right? She's not going to have transplant. It's just symptomatic palliative treatment. She doesn't want regular dialysis, but when she's unwell, she's swollen and all, she comes to you for palliative treatment. We don't deny palliative treatment. So why are we seeing this in a different way? Just as Crystal, you eat rubbish and you don't exercise and all that, and we don't control you. We don't say that if you don't do that, I'm going to give you a social contract. You come in with hypertension, I'm not going to treat you. Because you refuse to conform to the diet that we doctors say is good for you. So Madam Ng already has decided. She is aware. It's not that she doesn't have insight. She knows that if she doesn't have regular dialysis, she's going to die, right? It's her choice because she doesn't like to wait and all that. Same way as why somebody with leukemia doesn't want to treat because she doesn't lose hair or whatever reason. As long as we say that we are saying that it is, in somebody who has capacity, then why are we looking at best interest? We don't really need to consider best interest, right? So just as the same way as we don't deny palliative care, we really shouldn't deny her dialysis when she comes in extremis. And talking about the thing about not having enough dialysis slots, she actually is freeing up the dialysis slots for you because she's not doing regular dialysis. She's only coming in for emergency dialysis. So I really don't see why we don't.
Oh, this is why these conferences are so much fun. But it is true in the sense that you could make an argument that actually restricting or removing the privilege of dialysis from her could be viewed as punitive, could be viewed as punishing her, right, for the way that she's thinking or the way that she wants to behave. But again, on the other hand, and this is why it's so challenging, right? On the other hand, that sort of behavior does have certain consequences, not just on her, but on other members of the society, to the extent it frees up or clogs up dialysis slots. Obviously a discussion can be had on that. And absolutely right that you pointed out that she has capacity, but so many of these patients who are in this sort of situation, it could be argued that they're on borderline capacity. But then, borderline on what basis, right? Are they really making decisions? And then this is, I think, where we come into the best interest, where we would like to come in, I suppose, and make decisions for them that we think is going to be good for them, that are going to be wise and not unwise. But are we overstepping in doing that is the question. Okay, JJ. JJ is very passionate about this, obviously.
On what Mayo said, I think, I don't know whether Titus will agree, but my impression is that if you come in regularly for dialysis, the amount of resource that you're going to use, the amount of stress you're going to put on people in the dialysis center is much less than when you come in a catastrophic state and a crisis state and for people. So I don't think you're doing society a favor by freeing up slots, because when you fall very sick and you come in, it's going to be a bigger problem. I think that perhaps, maybe we shouldn't see this as punitive. This should not be seen, just for example, when we tell smokers to smoke in a certain area, we're not trying to punish them. We're trying to protect other people So I think, to me, it's mentioned that this is not purely about whether someone deserves. If we have endless resources, I think that's fine. Everybody's best interest can be met. But I think, this is something that I have gradually learned as I move from someone who's interested in ethics, and now I have to have some stewardship of resources. I realize that, the ethics only comes alive when you face reality. And the reality is that there are limited. Singapore is a small country with limited resources. Perhaps at this moment we feel like we're a country of plenty. We have all the reserves that built over the years. But soon we will face that problem. And as you know, healthcare costs is rising. Just have a thought experiment. If you have one slot only, and if you have two patients, one is someone who is trying his best to control his risk factors, and yet despite of that, because of his genes, whatever, he's doing all the right things. He's compliant, but he still needs the dialysis. And you have Madam Ng. Who would you give it to? Do we still say that these two persons' best interests? But you can't, you see, you can only meet one person's best interest. Who do you then not? You can't run away from making these judgments. As someone once said, there's a fallacy about God. Doctors should not play God. But what doctors must do is to be a wise God. Yeah, and have that courage to make, these are tough choices. These are very tough choices. But if everybody says, I'm not going to make this choice, and I'm going to allow, let's say, a first come, first serve, or, sort of basis, and let the lady luck decide, then I think we are sort of running away from our responsibilities of making these tough choices. And these tough choices are tough, but they have to be made because we are all sharing the same resources and responsibilities. You see, what her behavior is, her behavior is actually increasing her creatinine level. Then your dialysis is to reduce. So what she's doing is really countervalent to what she's coming for as a rescue measure. Yeah, I agree that bedside rationing is not a good thing. But I think that those of us who are actually stewards of these resources need then to come up with guidelines and policies to guide the general. And we must not shy away from making these tough decisions. You cannot please everyone, but I think we need to look at the overall best interest. Otherwise, I think dialysis centre are the one that's vulnerable, not the patient, because they're vulnerable to abuse. Thanks.
Thanks. Okay, I might want to wrap up case one because we've got another case, if that's okay. But I do also want to mention, we thought long and hard about what cases to include, and this case is the first case for a very important reason, because I think a lot of us are seeing these sorts of issues on the ground. I mean, for you as healthcare professionals, but certainly even in the Clinical Ethics Committee, we do see these cases. It's not uncommon, and we still have challenges in how we address them. So please do come and talk. I mean, I think there are quite a few of us who are interested in working on this and coming up with a more systemic solution about how we can approach problems such as this. So yeah, just a shout out if you're interested in looking a little bit more at this. Ooh, am I going the right way? Oh, it's kind of frozen. Hang on a second. Oh, don't you hate it when these scheduled scans appear on the screen and then let me just see if I can get rid of it and that fixes the problem. No, it doesn't fix the problem. Okay, so now on to case two. So this is a case of Mr. Song, who's 78 years old and lives with his 65-year-old wife, who's called Miss Ang. And they live in a two-room flat. Now, Miss Ang has few savings, and the couple draw on Mr. Song's CPF to fund their modest life because they're now retirees. They don't have any children together, but Mr. Song has an adult daughter from a previous marriage who does not live with them. His wife and daughter are not close, something that's always made Mr. Song quite sad. Now, he's been diagnosed with mild to moderate dementia, and he can make some decisions, but struggles with more complex matters, such as managing his CPF. He has a lasting power of attorney, which he has appointed his wife as his donee. Now, he stays mostly at home, but occasionally participates in activities at the Senior Activity Center near his housing block. Now, he was recently admitted to XYZ Hospital with pneumonia, high fever, dehydration, and appeared to be disoriented. He has since recovered and has even put on a little weight on his frail body. and he is now scheduled for discharge tomorrow. However, Mr. Song's daughter has now disclosed to hospital staff that her stepmother physically abuses her father. The hospital staff noticed bruises on Mr. Song, but they were consistent with his explanation that he recently had a bad fall in the bathroom at home. She wants her father to be transferred to a nursing home and is willing to assist with the arrangements. But she, Mrs. Song's daughter, also requested that the medical team do not inform Miss Ang, her stepmother, about her disclosure because she fears this will already worsen their strained relationship. She also indicates that she could reveal more details about the physical abuse, but only on condition that it is treated confidentially. The hospital staff now would like to buy some time and inform Miss Ang that her husband's discharge may have to be delayed. Miss Ang would like to know why this is and says she's keen to take her husband home as she had initially planned. She points out that she is Mr. Song's donee under the lasting power of attorney and therefore authorized to make these sorts of decisions on his behalf. Mr. Song himself is also eager to return home as soon as possible because the hospital environment makes him feel uncomfortable. And in an earlier conversation, he mentioned that he would not be keen on moving on a nursing home. The healthcare team conducted a mental capacity assessment on whether he can decide on placement, and they conclude that he lacks capacity to do so. Okay, so he lacks capacity to make that decision. So the first question is, what are the ethical concerns when considering whether or not to discharge Mr. Song from hospital? Okay, so the question we had is, what are the ethical concerns when considering whether or not to discharge Mr. Song? Would somebody like to give us your thoughts on what you think the ethical concerns are?
So first question, what are the ethical concerns when considering whether or not to discharge Mr. Song from the hospital? I think first and foremost, I think on our table we discussed that we need to be sure whether there is any ongoing abuse by the wife, whether the account is accurate by the daughter. In essence, I mean, some of the ethical concerns are also further brought up in question 3. Again, whether to disclose the information about the alleged physical abuse as well. So, I mean, this is a very unstructured approach, but yeah, these are some of the ethical concerns we have. And we also quite, I mean, I'm puzzled because the scenario seems to suggest that the patient has capacity because he has mild to moderate dementia, but at the end of the day, the assessment is that he has no capacity. So is that also accurate in a way? Do we need, another colleague brought up, do we need another assessment by another person? That's another one. Yeah, so some of the considerations. Thanks to me.
Thank you, Lambert, and thank you. I'm sorry, I didn't mean to shock you by picking you. Thanks for being so game and responding. Anybody else want to add to that? Tak Singh.
Yeah, I'm Tak Singh, Clinical Ethics Committee, NUH, and also the member in the National Organ Transplant Ethics Committee. I think the ethical consideration here for Mr. Song, basically on two. One is best interest, and the other one is autonomy. I think the issue is that the psychiatrist has already said that he has no mental capacity, but the doctor has a vested interest in his care. But interestingly, the doctor also said do not confide the information about him being bruised by the wife. But yet, the wife is actually the donee under LPA, and she therefore has decision-making right. The truth now is the problem, because I think at the end of the day, we need now to find out, based on the autonomy principle, what the wishes and preferences of Mr. Song when he was not mentally incapacitated. If that is not possible, then we must ask the daughter, since that's the only family he has, or his friends, and his very close colleagues, because I think the wishes and preferences under autonomy is very important. So we need to establish that. The fact that the doctor say cannot disclose this thing is a problem. Why is there a problem? If indeed, there is evidence that Mr. Song has been abused by the wife, it should come out to the natural that for him going home cannot be an option because he's been tortured. If that is the case, then it will be a police case. So to me, I think the dilemma or the conundrum is the inability for us to get information that is relevant to Mr. Song. But we know he doesn't want to go hospital and he doesn't want to go nursing home. That's what we know. And the doctor's wishes is for him to go there because he doesn't want the father to be abused. But that doesn't solve the problem because then his wishes are not being fulfilled. So I think best interest and autonomy is important. Distributive justice, not at play here because we're not talking about limited resources. We're not asking the state to finance his nursing home stay. Non-malfeasance, not at play here as well. So I think it's both best interest and autonomy of the patient. But I think we need more information. Thank you.
Thanks, Tak Singh. The panel, perhaps, or are there some more comments from the floor, or queries, or clarifications? Oh, yes. Are you coming to the...
Hi, Jing Yi, MSW here. I think one of the key, because patient has already been certified to have no mental capacity, so we are looking at best interest approach to the case, and therefore we are looking at welfare maximizing approach, right? So in this case, I think it's important to consider also whether the daughter's allegations is also arises out of her lack of access to the patient. Because we also know that if she has an acrimonious relationship with patient's wife, it's likely that patient's wife may not be allowing her access to the patient. And we also know that as an LPA donee, actually she has the right to kind of decide on access because the LPA donee's powers are broad. I think something to also consider, maybe not ethically but legally, is also whether or not the wife is still acting in patient's best interest. Because I don't know whether down the road there will be some contention about the validity of the LPA, or if not, whether or not the wife's powers needs to be revoked if she's not acting in patient's best interest. Normally at this point, when we look at the patient and we do not have any reasons to suspect that there's been allegations of abuse, maybe on account by us observing patient and wife's interaction in the ward, by taking the testimony of both the wife and the daughter. I think it's reasonable for us to discharge the patient to the care of the wife while setting in place the safeguards for patient, meaning putting in place community resources that can check in on patient, and if any time point, if we do suspect that the allegations could be true, and we can always then either raise it to APS or try to persuade the wife to then bring the patient back and for further assessment. Yeah.
Thank you, Singi. Okay. Panel reflections, perhaps, on this question, or any aspects you'd like to add to?
I think more information will help about how the case ought to be managed. For example, the veracity of the information that the patient has been abused. On the assumption that he really has been abused, then definitely best interest. But what Jing Yi said is also true, and what Jing Yi said is also correct, because sometimes could it be the daughter's way of trying to gain access to the patient? But if she cannot access the patient, I'm wondering how then therefore she knew that or suspects that he's been abused. Yeah. So I think there are some questions that they are left unanswered. But in the event that he's been abused, so does that mean that abuse means he ought to go to a nursing home? As an MSW, I would say no, because we best interest trying to see what the patient's wishes are, depending on the level of abuse, because we have to ascertain in what degree. The other thing also about abuse is sometimes abuse happens because the caregiver cannot manage. And persons with dementia, the caregivers are known to 3 times more likely than other caregivers to suffer from depression. So I think these are, even if abuse exists, we need to find out the context of the abuse. I think more like ascertaining the context of the abuse, whether, Mrs. Song is coping or not. And if there's abuse and we cannot engage her, then of course, then the protection, I would think that the protection for Mrs. Song would be more important. And it's not for the LPA to exercise her power then if we think that she may not put her best interests on the pedestal.
Ooh, bit squeaky. Okay. I think we've had quite a few discussions about the ethical aspects. I don't know whether Titus wants to also add something.
I think just 2 points. One, the first thing about assessment for mental capacity. I think maybe someone tomorrow is going to raise this as well in terms of, it seems fairly straightforward, right? Mental capacity assessment. In reality, again, it can be challenged. In reality, again, it's not always so straightforward. In reality, again, different people with different ability are asked to do this. If you look at the Act, any registered medical practitioner can do that. A professional like a psychiatrist can do that. I tell you very honestly, I have a patient in a ward with me whose psychiatrist came to do mental capacity assessment and wrote down because the psychiatry liaison person who came to do the assessment did not speak the language of that patient. She's a Malay patient and he was Indian, right? And so between the interpreter, between her crying and sobbing and everything else, he wrote down there no capacity to make decision. When I sat down with the patient, I tell you it was a very obvious case of an error because she definitely has capacity. She was very lucid, she was very logical in terms of her consideration, in terms of the difficulty of the decision making. By the way, I just want to add as well, if a patient cannot make a decision at that point in time, it does not mean that patient is incapacitated. All right? Sometimes the decisions are so tough because in hospital you are thrown one bad news after another, right? Anyway, if you get in the hospital, always bad news, all right? There's never good news to be in the hospital. So when you're in the hospital, first of all, you have the primary diagnosis. The next day, the doctor will come and tell you another diagnosis. They do a scan, and they find something wrong with somewhere else, which you didn't have complaints about, you didn't know, and you were oblivious and happy. And now you're worried more. So there are many, many major decisions that needs to be made as a patient sometimes, and I can really empathize with the patient how difficult it is. And sometimes they're just in a state of shock. They just need time, they need to process. But because we know public hospital is a scarcity and we need to move on. So sometimes we just don't give patient enough time to think about it. So just bear in mind that sometimes you can make a, especially if you don't communicate well with the patient. That's one key area, all right? The other thing I was thinking about as well and just came up is that as we're discussing this case and discussing scarcity of resources, right? Society has scarcity of resources. I'm a patient, my choices may be limited to. For example, let's say Mr. Song did have capacity, right? And let's say Mr. Song is actually emotionally abused, actually the wife scolds him every day and all that, And then he will ask the doctor, so what option do you have for me now if I should leave this situation? Nursing home, right? There's nothing else for me. So then if I'm given that option as Mr. Song, I have a wife who scolds me the whole day, or I want to go to nursing home. Which of these would I choose? I may still choose to go back to an abusive situation because I think being a nursing home is even worse off for me, right? And if I have the capacity to make that decision, I think I want to have that autonomy to make that decision for myself. I don't want Crystal to come in VAA and say, Titus, I'm going to protect you, I'm going to take you away. But take me away where? To your house? To a nice place? To my family members who love me? No, I don't have any other family members who love me. She's all I have. She scolds me the whole day. I think I can tolerate that. Maybe it's okay. That's better than to be confined in a nursing home, right? So I think we need to think of that in that context as well, because it's easy for us sometimes to be reactive to certain situations. But then I think many of you have raised this. What are the options actually that you have for the patient? Nursing home is not really a great option. And I think Taksin has pointed out, and the case history has elicited this as well. patient has expressly stated, I do not want to go to the nursing home.
Certainly, the autonomy aspects of it are going to be important here, even though the person doesn't have capacity currently, which kind of then takes us to that second question. But I think we've kind of answered it, and I'm trying to keep half an eye on time, right? I mean, we should try to involve him as much as possible. Just because he doesn't have capacity to make this specific decision doesn't mean he doesn't have values, wishes, preferences. And we already know he doesn't want to move into a nursing home, and he'd much rather be at home, even though, it might not be so conducive at home. But that also still needs to be investigated and followed up, right? Because you can't just, one allegation doesn't mean you call the police and then haul her away. I mean, it's way too early to do that. So certain additional steps need to be to take place now, and it's not immediately police Vulnerable Adults Act. No, it's not those steps right away. It's like an opportunity to kind of pause, which then kind of leads me to this question, which is quite an interesting one, I think, for us to think about. Somebody's already mentioned this, right? So this is another Paul Levy question. Should the healthcare team respect the daughter's wish not to disclose the information about the alleged abuse actually, it shouldn't be to Miss Ang, it should be to Mr. Song. So should the healthcare team respect the daughter's request not to disclose the information about the alleged physical abuse? Oh, I see. Basically, should they respect, I've just realized I've phrased this question terribly. What it means is, should they respect the daughter's wish to keep that information away from Mr. Song's wife? So in other words, not tell Mr. Song's wife. So in other words, they won't tell Miss Ang that the daughter is saying that she is abusing the father. Wow. Now that is interesting. Ooh. Huh. I'm very curious now. Very, very curious. Okay, because we're almost split down the middle, except for that 12%. Very steady, those unsures. Is it the same 12, 15, 13, 14%? That's what I want to know, right? Are you the same people sitting on the fence? Okay, for the rest of you, it looks pretty much clean split down the middle. Can somebody who said no, please tell us why? Please don't be shy. Come on. We're amongst friends, remember? So in other words, you don't think we should respect her wish, and in other words, it should be disclosed. So in other words, you should go and tell Miss Ang, your stepdaughter has said these things about you. The lady who's saying no, do you want to tell us why no?
Hi, I'm Pei Wen from Hospital Kuala Lumpur. I was saying no, that I will not tell the wife that your stepdaughter accused that you have abused my father. I answered yes, but I need to justify because just now my no is to your statement just now.
Oh, okay.
Yeah. So I said, yes, I will not tell the wife that what the stepdaughter has told me as a doctor. However, I will use myself as a clinician in charge to explore further about the bruises rather than putting the stepdaughter in the picture. So this is my answer, yes, with a clarification.
So yes, you won't drop her in it now until you do a bit more investigation.
Yep.
Okay, thank you. Well, somebody who said no. Apparently half of you said no, so there are quite a few of you here. Who wants to volunteer? Oh, please don't make me ask. Or pick people. Or pick a table. Table 8, since Matvi's right next to it. Lucky 8. Suresh, Reshna, I can call her.
Hi, sorry, Sumi. I actually misunderstood when you tried to clarify. I got a bit confused, and when I locked it in, it was meant to be yes for me.
So, it's okay. Hisham, did you say no?
No, I said yes. Yeah.
Anybody there said...
No, but this wasn't to clarify exactly why she wants to keep the information away from the patient's wife. I mean, there must be a background to it, right? I think that's why, I think the earlier statement that we...
Oh, unsure.
Yeah, but the reality of it, I will still hold until I can get more information. It is an allegation. It is a serious allegation, no doubt. But we need more information to understand what is the real picture. I mean, we heard about people may have vested interest and whatnot about what's happening, right? I mean, I also put in my mind, she's talking about physical abuse, but there could be more than physical abuse here.
True.
I think Titus alluded there could be emotional abuse. There's also money, financial abuse possible. I mean, it goes on and on, right? But at the end of the day, we don't have enough information to decide what is really happening.
Okay.
But then again, patient is medically fit for discharge, right? You look at the current occupancy rate, most people will say, maybe go home, send people to follow up, get the real picture, understand what is really happening, work with the family service centers and whatnot. Then maybe we get a better picture. But someone needs to keep an eye on this guy to know what is really happening. Yeah, because sometimes the abuse doesn't come out until later on you realize, oh my God, it's really happening in a big way. Yeah, and I guess suppose that's why I think that at the end of the day, we still need more information. Don't forget that we may want to use the daughter as an ally, so disclosing too early will get her, not on our side, so it might be difficult later on, right? So I think we need to play our cards right. At the end of the day, more information is always good. Thanks.
Thanks, Hisham. Maybe I should have the option, it depends. But then if I have that option, I think most people will choose on the it depends. Kumu, it's interesting, isn't it? Interesting.
So I didn't answer the question, so I'm coming from a different perspective. Hi, I'm Kumu, I'm from KK Hospital. I deal a lot with child protection issues and safety issues. So, and I would probably be in the unsure group together with Hisham, mainly because we don't have enough information. Again, this is an allegation. And as healthcare professionals, we are supposed to keep our patients safe. So that's the key part that you're there. And it's a significant allegation. So in the conversation where she says, you cannot tell, I get this a lot because I deal with teenagers a lot. Don't tell my mother, don't tell my this, don't tell my that. At the end of the day, the confidentiality statements doesn't state who you're going to tell. But harm to self, harm to others, others harming you. 3 things. I can break confidentiality. And I will be very clear to Mr. Song's daughter to say that if there is any reason I feel there is, I may not have to tell your stepmother, but be rest assured I will be informing appropriate authorities. And that will be very clear at the outset for me, because I have to deal with this a lot. And I deal with this with teenagers, and I tell them what I can and cannot tell. Everybody is allowed that confidentiality. Again, Mr. Song's daughter is also not your patient, right? So in a way, I always bring it down very simply. For me, I have to think in that way. Safety. If there is a threat of safety to my patient, I will do what I feel is ethically required and legally required to do for my patient. And I think that's a very simple way in order not to postulate about she has an agenda. We're not CSI, no, we are not SPF, so we do not have to go and do all of these things. Do I have evidence that he is being abused? This is what we look for when we forensically examine children, to look for evidence of abuse. Do I have anything but an allegation from one person that this man is abused? Can I just ask Mr. Song or not?
Thank you. Okay, keeping half an eye on time here. So I'm just going to do 1 minute of some key takeaways just to wrap this session up, and then we'll go for lunch and come back at 2 o'clock, okay? So I think we already know it's extremely challenging to manage patients like Madam Ang, but this whole thing about balancing resources, and I think some people have already mentioned, do we stop medical services for patients like addicts when they can struggle to overcome their addiction? So if we continue to provide help and support to addicts, should we do the same thing for patients who are like Madam Ang? I think we also mentioned earlier on about being careful to ensure that refusing to treat such patients isn't perceived as a punishment. But of course, there are always limits in line with justice and resource allocations, especially if patients are abusive or they are disruptive in terms of providing service, in terms of other people accessing services. On Mr. Song, the ethical concerns were really to prevent harm to him, since there's an allegation from the daughter about this potential abuse. The decision on care placement is actually a personal welfare decision, so it would have been the wife with the authority to make decision on his behalf. That's when it gets really tricky. If it turns out that your donee is not acting in your best interest, then you probably have to go and, if you have further suspicions, report it to the Office of Public Guardian. They're the ones who will investigate. They are the ones who will proceed if it's a criminal offense under ill treatment, if it gets to that stage. I think you know already about involving the patient as much as possible in terms of helping them make decisions, involving them, participating in the process of decision making. Now, although Mr. Song lacks capacity, his views should be considered. He's more comfortable at home rather than nursing home or hospital. But of course, things might change if the allegations of physical abuse are substantiated. So other alternatives, perhaps living with the daughter, could be looked into if we get to that stage. And I think that's it.